Pleasure to welcome you all. ONCO Meet 2025. It's day 2, and I would like to invite Dr. Abhishek Anand sir for giving opening remarks. So it's over to you, sir.
So, good evening to all of you, and I would like to thank all the esteemed faculties who have joined yesterday and today as well. So, today is day two of OncoMe 2025. Yesterday, we had important sessions on GI cancer, lung cancer, as well as a few important updates from the important conferences that happened in the past year. Now, today we'll be having important updates in the gynecological cancer, urogenital cancer, as well as the breast cancer, and important few of the important trials of NSCLC. And to start with, we have got Dr. Nihanti, and who is my junior as well from Kolkata and a senior medical oncologist. So over to you, Dr. Nihanti, for the first talk.
So, tech support, can you pause?
Is my screen visible?
Uh, no, sir. Can you please reshare again?
Yeah, just a second. Is it visible now?
Mm, it's sharing, sir. Yes, sir. It's visible now.
Okay, thank you. So I'll be talking about role of maintenance PARP inhibitors in ovarian cancer. We all know PARP inhibitors work beyond BRCA. Nowadays, we have enough data to safely say this, and we'll be looking the data of niraparib as maintenance first-line therapy after primary treatment in epithelial ovarian cancers. So these are my disclaimers. This session is being sponsored by GSK, and I'll be discussing the data of niraparib. So this is how ovarian cancers are being managed in 2025. Initially, we do debulking surgeries, or you can say our target is to reduce the volume of tumor. We have several approaches, and most of the time, if it is advanced disease, then we go for neoadjuvant therapy to reduce the tumor burden, and then we go ahead with surgery. Once you are done with primary treatment, you have basically two options to offer to your patients. One is to give some sort of maintenance therapy, which is routinely being done nowadays based on the genomic reports. Initially, earlier days we had option of observation. So problem with observation was most of the patients had recurrence. Nearly 70% of patients with advanced epithelial ovarian cancers will have some sort of relapse in the first 3 years in the absence of maintenance first line therapy. And in our clinical practice, what we see, most of the recurrences happen within the 16 to 18 months of primary treatment. So despite giving best of your efforts, majority of patients do have relapse. That's why there was an unmet need of something which is to be offered to prevent such relapses. So this is how maintenance therapy, or you can say interventions, has evolved over a period of years when it comes to offering first line maintenance therapy. We have data from different trials for PARP inhibitors. The trial involving olaparib, solo one trial, they included only BRCA mutated patients. But we all know PARP inhibitors work beyond BRCA if it is HR deficient, or even if homologous recombination proficient also, then also it works. So we have several trials done for different drugs, and one such trial is primer trial, where niraparib was given as first line maintenance therapy. So that these are different PARP inhibitors which are being used for epithelial ovarian cancers as a maintenance therapy after first line treatment. Niraparib can be offered, or niraparib is offered to all patients irrespective of their BRCA status. irrespective of their homologous recombination pathway status. Rucaparib is offered across all biomarker subgroups, but this drug had some issues, and there was a discontinuation of this drug in between, approval discontinuation. But now we have data from Athena mono trial. We have data for olaparib as well, but this is to be offered if patient has BRCA mutation. And if you have used bevacizumab in first line therapy or primary treatment, then we have data from Paula trial. Olaparib with bevacizumab to be given if BRCA is mutated or HRD is positive. So these are different guidelines which establish the role of PARP inhibitors as first line maintenance therapy. So American Society of Clinical Oncologists, they say that PARP inhibitors maintenance therapy should be offered whenever it is feasible. If patient has BRCA mutation, we have different options. Even if patient has homologous recombination proficient status as well, then we have also drugs to offer as first line maintenance. And similarly, ESMO guidelines also state that patient having either even in HRD negative population, this subset of patients can have PARP inhibitors. So what about the real world, PFS advantage with these PARP inhibitors? So patients who are diagnosed with advanced ovarian cancer, they have we have data from US database, who after completion of first line platinum based chemotherapy either received PARP inhibitors monotherapy or they underwent active surveillance. So PARP inhibitors cohort received first dose after the last dose of platinum-based chemotherapy, and active surveillance. They were put on observation. So you can see the PFS curves are getting separated beautifully, and PARP inhibitors do have advantage of in terms of progression-free survival when offered as first-line maintenance therapy as compared to active surveillance. So median PFS is not reached in the PARP inhibitors subgroup of patients versus 9.5 months in active surveillance. Now, despite we all are aware of eligibility of patients who can be offered PARP inhibitors, but still majority of patients do not receive it. Particularly where I practice, I think most of the patients have financial limitations and they have difficulty in access to these PARP inhibitors, despite being availability of now generic molecules as well. So in this pie chart, you can see nearly 56% of patients still, are put on active surveillance, and only 30% of patients receive PARP inhibitors, despite being eligibility for PARP inhibitors. So these are different considerations we have to look for whenever we plan any treatment for newly diagnosed advanced epithelial ovarian cancers. It can be patient related factors in the form of age, comorbid conditions, performance status. It can be disease related factors like stage of disease, histology, whether it is mucinous, whether it is high grade serous carcinoma, and genomic profiling as well. Nowadays, we routinely do genomic profiling of epithelial ovarian cancers. It has to be done, it is a must. And we go beyond BRCA as well. We perform genomic testing for homologous recombination repair pathway defects. So this is how we should manage advanced epithelial ovarian cancers. If it is homologous recombination deficient, then if it is BRCA mutated, then after chemotherapy, we give PARP inhibitors either for 2 years or 36 months. We can give PARP inhibitors with bevacizumab if BRCA is mutated or if it is homologous recombination deficient. In those patients who are BRCA wild type, after chemotherapy, we can offer PARP inhibitors in the form of niraparib, even if it is homologous recombination proficient. or PARP inhibitors can be given with bevacizumab. One thing is, with PARP inhibitors, if disease is platinum resistant, you don't get response with chemotherapy, then PARP inhibitors are not going to work. They work only in platinum sensitive settings. So most of the patients who have platinum resistant disease, they should not be offered PARP inhibitors. Now, coming to my talk about niraparib, why it is different from other PARP inhibitors, what are the differences when it comes to pharmacokinetics? So, niraparib is a highly potent and selective inhibitors of PARP1 as well as PARP2. Uh, PARP trapping potency of niraparib is two times than that of olaparib or rucaparib. And niraparib achieves high drug concentration in tumors and delivers sustained PARP inhibition. Niraparib inhibits tumor growth in both BRCA mutated as well as BRCA wild type tumors. So it is a bit different from other PARP inhibitors, and we will see the data of PRIMA trial as well. They included bad patients in this trial, which is close to our real world practice. So this is the landmark trial, PRIMA trial, phase 3 randomized trial, where patients were randomized in 2:1 fashion to either receive niraparib or placebo, and niraparib was given at a dose of 300 mg once a day for 36 months, and primary endpoints being progression-free survival as by blinded independent central radiological review. Key endpoints being secondary endpoints being overall survival as well as PFS2 and time to first subsequent therapy. Patients were stratified whether they have received NSCT or not. Then the best response to platinum-based therapy, whether it was CR or PR, and homologous recombination status, whether it was deficient or proficient. So these were stratification factors, and if you see the data or stratification factors, then patients nearly 2/3 of patients who were randomized in this trial, PRIMA trial, they received prior neoadjuvant chemotherapy. That means most of the patients had advanced disease, and they required neoadjuvant chemotherapy. And we all know, if you have requirement of neoadjuvant chemotherapy, which is an again high risk feature for recurrence. If you see, then 99% of patients with stage 3, they had visible residual disease after primary cytoreduction. And patients had to have either CA-125 in the normal range or CA-125 decreased by more than 90% during their frontline therapy for more than 7 days. And molecular profiling was done. 30.4% of patients had either BRCA mutation positive or homologous recombination deficiency. 20.5% of patients had HR deficiency but BRCA wild type. So if you see the 5-year PFS curve or 5-year PFS rate, then intent to treat population, that means all comers, 5-year PFS rate is 22% in niraparib arm versus 12% in placebo arm. 3-year progression-free survival rate is 29% versus 18% in intent to treat population. If you see this data by subgroup analysis in the form of homologous recombination deficient population, then 5-year PFS rate was 35% versus 16% in placebo arm. And homologous recombination proficient population of patients, 5-year PFS rate is 8% versus 7%. And across these three subgroup of patients, hazard ratio was positive and it was less than 1. In HRD population of patients, hazard ratio was 0.51, and median progression-free survival was 24.5 months versus 11.2 months in placebo. Now we have long-term follow-up data as well. So at the end of 6.2 years follow-up, observed 5-year progression-free survival rate were 22% versus 12% in intent to treat population, 35% versus 16% in homologous recombination deficient population, and 8% versus 7% in HR proficient population. Now, once you give these drugs for a long time, particularly for 36 months, you are exposing any patients. So we have to look for quality of life for those patients. So patient-related quality of life was not deteriorated when you give niraparib as compared to placebo. So the quality of life of these patients while being on maintenance niraparib for 36 months, it was maintained. Now, we don't have very encouraging data when it comes to overall survival, but we will discuss why it is happening like that in subsequent slides. So, if you see the 5-year overall survival rate with this primer trial, it is 42% in niraparib versus 44% in placebo with a hazard ratio of more than 1. In patients having homologous recombination deficiency, 5-year overall survival rate is 55% versus 56%. So if you see these curves, then these data are not that encouraging, but there are very valid reasons for not getting overall survival benefit with this drug when it is given as first line maintenance therapy. So, if you see subsequent PARP inhibitors therapy, you put patient on observation after primary treatment, then ultimately they are going to receive PARP inhibitors in as their subsequent treatment, and majority of these patients are going to receive PARP inhibitors in subsequent line. So, most predominant in homologous recombination deficit population. Obviously, there are regions with highest use being in HRD positive or BRCA mutated population. In those patients who received subsequent PARP inhibitors, more than 80% of patients treatment initiated in their second line therapy. Now coming to toxicity, so anemia, thrombocytopenia, and nausea, these three are the most common toxicity which are experienced with different PARP inhibitors. And similar to other PARP inhibitors, here also with niraparib, these three are the commonest toxicity. Nearly 67% of patients had some grade of thrombocytopenia, 65% had some grade of anemia, and 58% of patients had nausea. If you see the grade 3, grade 4 toxicity rates, then particularly problematic is nausea and anemia. Nearly 20% of patients, 20 to 25% of patients had some grade of grade 3 nausea, more than grade 3 nausea, and 30% of patients, means one third of your patients, are going to have grade 3 anemia. If you see the long-term toxicity, which we discuss sometimes, is MDS AML rate, then this is not very different when it comes to giving it for 3 years. Rate of MDS AML is 2.3% with niraparib versus 1.6% with placebo, and there were no significant differences when it comes to treatment-related adverse events, discontinuation, or death. So key takeaway from this trial is this is a positive trial, that's for sure, and this is a practice-changing trial. It met its primary endpoints when evaluating niraparib monotherapy for first-line maintenance in patients with newly diagnosed ovarian cancer at high risk of recurrence after first-line platinum therapy. So it has demonstrated sustained and durable PFS benefits at 5 years in intent to treat population as well as homologous recombination deficient population. Final overall survival analysis showed no difference between the treatment arms in treatment intention to treat versus and HRD population. Final primer analysis confirms that sustained and long-term efficacy and safety profile of niraparib to support the benefit of niraparib as first-line maintenance therapy regardless of homologous recombination status. Now we see what are the clinical, trials when evaluating the right treatment for patients. How we should interpret whether we should look for progression-free survival, whether we should look for overall survival only, and whether how crossovers affect the study results as well as patient characteristics. So if you see the probability of showing, a statistically significant difference in overall survival decline. So if you see the PFS being long, progression-free survival, if it is long, then you are less likely to get, overall survival difference when it comes to true treatment sum. So OS, despite being a reasonable primary endpoint, when the median progression-free survival is short, that is less than 6 months, it is more likely to be reflected in overall survival if you are giving a particularly effective drug. But if it is long, PFS is very long, more than 12 months, and in this trial PFS is very long, so that's why you have issues or confounding factors when it comes to overall survival data analysis.
So sorry for interrupt you. Can you conclude your talk 2 3 minutes?
Yeah, just I need 1 more minute, just thank you. So if you see the overall survival data with niraparib, then overall population, it is 48.8 months with placebo versus 46.6 months with niraparib. HRD population 69.8 months with placebo versus 71.9 months with niraparib. And homologous recombination proficient, it is 32.2 versus 36.6 months. So we don't have overall survival benefit, but we have significant PFS benefit. And these are the subsequent treatment which patients received after progression. Most of the time, they receive only chemotherapy plus minus targeted therapy. And if you are not exposing patient in maintenance therapy, then we have options of giving PARP inhibitors as well in even in recurrent settings. So, what are the risk factors when we discuss ovarian cancers, and what are the factors which are associated with survival? So, age is one of the factors, performance status is one of the factors, disease stage, obviously, higher stage is associated with poor prognosis, BRCA mutation study, homologous recombination status, surgery modality, and residual disease. So if you see the different trials of PARP inhibitors and the population they randomized, so PRIMA trial probably had the worst subset of patients. So nearly 35% of patients had stage 4 disease, 47% of patients had visible residual disease after their primary cytoreduction, 67% of patients received neoadjuvant chemotherapy, and 31% of patients had partial response to therapy, and 70% of patients had BRCA wild type. So across the subgroup, or you can say randomized patients of different trials of PARP inhibitors, PRIMA had worst subset of patients, and despite having worst subset, it showed good results. So if you see the PFS, progression-free survival result in those patients who had visible residual disease, then it is one of the factor which is associated with worse prognosis. If after primary cytoreduction, if you have visible residual disease, then your patient is going to have bad prognosis, and it is reflected in PFS in different trials as well. So to summarize this talk, PARP inhibitor maintenance therapy has shifted the paradigm of care when it comes to treating advanced epithelial ovarian cancers, irrespective of histology, whether it is serous or mucinous, and across biomarker subgroups. Personalized first-line maintenance treatment involves complex treatment decision making, utilizing multiple complementary tools and factors beyond biomarkers, including chemotherapy responsiveness, disease risk group, patient characteristics, and personal preferences. In addition to biomarker status and other factors, response to platinum-based chemotherapy is a key predictive indicator of PARP inhibitor benefit, and this should be assessed after 1 to 3 cycles. There are different tools to assess the platinum response. Tolerability of efficacy and the totality of efficacy and safety data across PRIMA, PRIME, and real-world evidences. These support the use of niraparib irrespective of homologous recombination status, who respond to first line platinum based chemotherapy. With this, I would like to stop. Thank you all for your patient hearing.
Thank you so much, Dr. Chandrasekhar sir. Is there any question? Please keep on chat box. So moving ahead for the next session. So next session is sponsored by AstraZeneca. And I would like to invite Dr. Avinash Upadhyay, sir. He's a medical oncology, Mithila Cancer Care, Patna. So it's over to you, sir.
Um, Hi, good evening, everyone. Can you can you share the slides from your end?
Jhalak, can you please share?
So, I'll be discussing today about the precise pathological diagnosis of HER2 low and ultra low expressing breast cancer. As we know, there is a new drug in the market, TDXT, which has changed the paradigm of management of patients who are having HER2 low and ultra low expression. So, precise pathological diagnosis is required so that we can use this drug wisely. So HER2 testing has evolved to improve the identification of HER2 positive breast cancer. So pre 2007 in the early 2000, HER2 positive was defined only as IHC basis, 3 positive, strong, complete membrane staining more than 10% of tumor cells. Then after 2007 2013 there was a revision, and they brought the concept of fish testing. And after that in 2018 ASCO cap guidelines updated the clarified ISH equivocal results. So earlier ISC3 only was taken as positive, now ISC2 required to undergo FI like fish testing, and based on that we could have seen whether it is positive or not. And 19 German oncology group also published the updated guidelines. And currently, if you can see, ASCO cap updated guidelines that forms prior HER2 testing, and the relevance of not only 2 plus or 3 plus versus IHC 0 versus 1 plus scoring. And ESMO publishes expert consensus on HER2 low breast cancers. Next slide. So HER2 ISC identification, we know 3 positive means circumferential membrane staining that is complete, intense, and more than 10% of tumor cells. 2 positive is weak to moderate complete membrane staining observed in more than 10% of tumor cells. ISC 1 positive becomes incomplete membrane staining that is faint or barely perceptible and in more than 10% of tumor cells. Zero means no staining observed, or there is a membrane staining that is incomplete or barely perceptible and it is present in less than 10% of tumor cells. So ISC2 positive goes for reflex FISH testing, and based on FISH scores, we calculate whether it is HER2 high or low. Next slide. So HER2 status is determined by ISC. So HER2 ISC 0, 1, 2, 3 as we have discussed. And then we go for FISH testing, and FISH testing we see for the see actually the ratio, and based on that ratio we determine whether it is we have to take for this HER2 directed therapy or not. Earlier, 0 and 1 plus was taken as HER2 negative. Now these are taken as HER2 low or ultra low. Next slide. So you can see now this HER2 0 can be HER2 negative ISC 0. 1 positive goes into HER2 low. HER2, if it is 2 positive and if it is positive by FISH, it becomes HER2 positive, and 3 positive is HER2 positive. So this HER2 low concept has come recently. Next slide. So what is HER2 recommendations provide guided guidance on updating the pathology practices to include HER2 low classifications. So in France, there was a guideline which was published, recommendation to explicit record details of HER2 staining characteristic and the resulting IHC scores in pathology reports. IHC 1 plus or IHC 2 plus and FISH negative is classified as HER2 low. Recommendations on testing and retesting for HER2 new invasive breast cancer at diagnosis, recurrence, or metastatic relapse, or when a false negative result is suspected. Recommendation for pathology laboratories to use calibrated controls and participate in question answer schemes for HER2 testing, including accuracy of distinction between IHC 0 and IHC 1 plus. And the explanation of why HER2 low is important in context of emerging HER2 targeted therapy, as I discussed, including TDXT in is provided. Next slide. So, 2022 UK updated recommendation for HER2 assessment in breast cancer. So, refinement of scoring of accurately identifying HER2 low and reflex fish testing only required with ISC 2 plus. So score zero was no membrane staining as we discussed, or faint or barely perceptible less than 10%. So HER2 negative score zero becomes HER2 negative, but patients who are having so the biopsy sample who are having score 1 plus earlier, which was HER2 new negative, now and with FISH testing the amplification was not there. Now that is being taken as HER2 low. HER2 score 2 positive with FISH testing showing that the amplification is present. The ratio of HER2 CEP17 ratio, if it is more than 2, or an average HER2 copy number more than 6, they are taken being positive. And if HER2 new score is 3 positive by ISC, it is taken as HER2 new positive. Next slide. So HER2 ISC 0 less than 10% incomplete staining. 1 plus is more than 10% weak incomplete staining, which is being taken as HER2 low, as well as the patients who are having 2 positive HER2 ISC, which is negative by FISH, that is also being taken as HER2 low. So this component has become very important in the context of newer HER2 directed therapies like TDXT. HER2 new 3 positive, we know more than 10% strong circular staining. Next slide. So two important recommendation on HER2 low was given by ESMO consensus and ASCO CAP guidelines. Next slide. So leading European pathologists developed the ESMO expert consensus statement on definition, diagnosis, and management of HER2 low breast cancer. So HER2 low is basically two groups. One is HER2 1 positive, so incomplete or faint staining in more than 10% of invasive tumor cells, and HER2 2 positive, which is non-amplified, so weak to moderate staining in more than 10% of invasive tumor cells, which is FISH negative. So these two group has been labeled as HER2 low, which was initially labeled as HER2 negative. When you see the ASCO CAP to 2018 guidelines, it was HER2 negative. But when now the revised guidelines 2023 guidelines says that if it is HER2 new 1 positive or HER2 new 2 positive, which is FISH non-amplified, they will be taken as HER2 low. Apart from that, HER2 new 2 positive, which is FISH amplified, or HER2 new 3 positive, they were earlier also taken as HER2 positive, and now also they are being taken as HER2 new positive only. Next slide. So pathologists can make best practice effort to distinguish IHC 1 plus results from 0 by the following good laboratory practices. So as we follow good clinical practices, pathologists need to follow good lab practices, and how they can do that. So examining HER2 IHC stain slide using standardized ASCO CAP guidelines scoring criteria, examining HER2 ISC at high power 40 times 40x when discriminating 0 from 1 plus staining, considering second pathologist review when results are close to 0 versus 1 plus, interpretive threshold more than 10% of cells with incomplete membrane staining that is faintly or barely perceptible. Using controls with a range of protein expression, including 1 plus, to help ensure the assay has an appropriate limit of detection, and careful attention to pre-analytic condition of breast cancer tissue sampling for both primary and metastatic sites. Next slide. So pathology labs should include a footnote in their HER2 new testing reports, ISC and in situ hybridization, with the following recommended comment that patients with breast cancer that are HER2 ISC 1 plus or ISC 2 plus is negative non-amplified may be eligible for a treatment that targets non-amplified, non-overexpressed level of HER2 expression for cytotoxic drug delivery. ISC 0 result do not result in any eligibility currently. So the semi-quantitative ISC score must always be reported as well to ensure the patient who meet the eligibility criteria for trastuzumab deruxtecan that can be identified. Next slide. So, HER2 factor testing in breast cancer, the ASCO updated guidelines you see. So, it includes that a footnote in their HER2 test has to be added with the following recommended. A patient with breast cancer who are HER2 new ISC 3 plus or 2 plus or fish amplified may be eligible for several therapies that disrupts the HER2 signaling pathways. But the patient who are having HER2 ISC 1 plus or 2 plus and fish non-amplified may be eligible for a treatment that targets non-amplified and non-overexpressed level of HER2 expression for cytotoxic drug delivery. ISC 0 may not result in any eligibility currently, but ISC 1 plus or 2 plus fish non-amplified, they have a target now. Next slide. So this is the how we see. So 40x we need to see the intensity, completeness, and extent. So to describe whether it is ISC 0 or ISC 1 plus. So this is important. Whenever a pathologist is seeing this, they have to see this specimen and 40x. Next slide. So intensity, that we know that we see both the intensity and completeness, and we see the percentage of cells, and accordingly we give a score. So for HER2 new 1 positive, it is faint, complete, more than 10% or less than 10%. We see for that. So if it is, even if it is faint, incomplete, but it is present in more than 10%, this is being given as a score 1 plus. Or if it is faint, complete, more than 10%, it is being given as a score of 1 plus. So this 1 plus and 0 is very important to distinguish, and this area has to be marked. Apart from that, if there is a strong or moderate intensity and complete or incomplete is there in more than 10%, we know that it will be 3 positive or 2 positive. So that is not a, that was not a, was a problem. The problem was when there was a faint or incomplete expression. But if it is more than 10%, it is to be classified as 1 positive rather than 0. So pathologists have to focus this area because this becomes eligible for HER2 low directed therapies. Next slide. So HER2 ultra low, so DB6, the trial, phase 3 trial to investigate TDXD versus taxane or capecitabine patient with metastatic ER positive breast cancer progressing on endocrine therapy included those with HER2 low and HER2 ultra low, and it has 10% of the patient with TNBC and no HER2 ultra low. So potential for expanding use of TDXD to first line setting following ET failure in expanded set of patients. Next slide. And HER2 ultra low, so how this was defined? So membrane staining complete is more than 10% becomes HER2 3 positive. 2 positive we have already discussed. 1 positive is incomplete, that is faint or barely perceptible more than 10%, or membrane staining incomplete and faintly perceptible less than 10%. That becomes HER2 score 1. And if it is more than 10%, become HER2 score 1 positive. If it is there, but it is there in less than 10%, so incomplete, faint or barely perceptible. If it is there even in less than 10% of tumor cells, that becomes HER2 ultra low. If there is no staining at all, then only we are going to say it is a HER2 negative. Next slide. So negative is no membrane staining detected. So it shall be completely absent. Membrane staining that is incomplete or faint or barely perceptible and less than or equal to 10% of tumor cells. So earlier this was like negative. Now this membrane staining that is incomplete or faint or barely present less than 10% is being taken as HER2 ultra low. Next slide. So what do we mean by HER2 ultra low? So as we have discussed right now, so the so in today's era, if there is any staining, if it is faint, even partial, it is present in less than 10%, this is to be taken as ultra low. If it is more than 10%, faint, barely perceptible, but it is in more than 10%, it is being taken as HER2 low. And if there is no staining at all, then only it is being taken as HER2 negative. Next slide. So changing paradigm of HER2 testing in breast cancer. So earlier we used just by ISC, then we came with FISH scoring. Now with the definition of HER2 ultra low and low, we know that even some staining, faintly barely perceptible staining does matter, and we pathologists have to be careful regarding reporting this because we know there is a drug which can target this population. So as per 2023 ASCO CAP guideline, the ISC 0 category includes both HER2 null and ISC more than 0 but less than 1 positive. So HER2 ultra low comes into this subset. Next slide. So 2025 CAP guidelines currently what is showing that negative means no staining observed, or membrane staining that is incomplete or faintly or barely perceptible within less than 10% of the tumor cells. They are being taken as negative. So low, ultra low, and no staining observed, they are being taken currently as negative. Rest, even more than 10%, if it is faintly or barely perceptible, is being taken as HER2 low. Next slide. So the patient, this is the guidelines from NCCN 2025. So the patient who are hormone positive, HER2 negative, uh, if uh, if they are having this hormone positive and HER2 with visceral crisis or endocrine refractory tumors, first line no germline BRCA1-2 mutation or FISH HER2 0 plus 1 plus or 2 plus and FISH negative, systemic chemotherapy becomes category 1, and then there is an indication that you can give TDFC also to such patients. Next slide. So examine at both low and high magnification. Lower power identify the heterogeneity. Visualize what 10% of tumor area would look like. High power identifies weak and faint staining. Only linear membrane staining is scored partial membrane staining. Determine the extent, the percent of staining. When close to cutoff, it may be necessary to perform the actual cell count. Access all tissues at 40x before staining as scoring as HER2 0. Recognize the staining pitfalls. 2023 upgraded guidelines to include footnotes, as we have discussed, and 2025 template recommend to quantify the negative score, whether it is 0 or 0 positive, which are categorized as ultra low. Next slide. So that was all from my side. Thank you. I'll hand over to the organizers.
Okay, thank you, Dr. Avinasa. So, is there any question? Please keep on chat box. So, moving ahead for the next session. So next session, I would like to invite Dr. Nikhil Himtani, sir, and he's a consultant medical oncology and hematology, Batra Hospital, Delhi. So it's over to you, sir.
So good evening to all my dear colleagues, and first of all, I would like to thank Dr. Abhishek for inviting me to his webinar conference. So today I'll be discussing regarding the management of unresectable HCC. So I would request the organizers first of all to share the slides.
Jhalak, can you please upload sir PPT slide?
Yeah, can you make that? Yeah, first, yes. So today I'll be speaking about the newer therapies which have come up in the first line setting in advanced unresectable hepatocellular carcinoma. Next slide. So as we know that liver cancer is the seventh most common cancer and fourth most frequent cause of cancer related death globally. So that is the global incidence where the incidence is it is the seventh most common cancer, and the global mortality is around is fourth most frequent cause of cancer related death globally. Next slide. Unfortunately, most of the patients which we see in our OPD are diagnosed with advanced disease. Very few subset of patients have localized disease which are amenable to resection. But most of the patients which we see have either multicentric, multifocal HCC or with portal vein tumor thrombosis. So nearly 50% of the patients who present to us in our clinic have advanced disease at presentation, and we know that the prognosis for these subgroup of patients is poor. As we can see that for patients who have localized disease, the 5-year overall survival is 30%. For patients who have regional metastasis, the 5-year survival is around 10%. And for patients who have distant metastasis, the 5-year survival is merely 2%. But fortunately, we have newer therapies, and that has changed the paradigm of treatment of advanced unresectable HCC, as well as the overall survival has also improved with newer therapies. Next slide. So the incidence in India, it is not that common as compared to the global scenario. It is the 11th most common cancer subtype and 8th most common for cancer-related death, while SCC being the second most common cancer death in men. So as per the Globocan 2022 data for India, the incidence is around 38,000 with mortality around 36,000. It's a male predominant disease with males to female ratio of 4:1, with median age of presentation of 40 to 70 years, and the frequency increases with increasing age. Mostly it is seen in cirrhotics, but it can be seen without patient having underlying cirrhosis. The incidence is very rare. As previously mentioned, the incidence of patient who have advanced stage is around 50%. That is patient having either BCLC-C disease, BCLC-C when we call the patient as portal vein tumor thrombosis or extrahepatic disease, and BCLC-D is when the patient is having either poor performance status, or the patient is having Child-Pugh score of C, that is decompensated CLD. Next slide. So, what is the risk factor for developing HCC? So basically, cirrhosis serves as a nidus for development of hepatocellular carcinoma, and cirrhosis mostly we see because of three factors. Either it is non-alcoholic fatty liver disease, which is the metabolic syndrome, patient having obesity, diabetes, and fatty liver eventually leads to non-alcoholic steatohepatitis, NASH, finally leading to development of non-alcoholic fatty liver disease, cirrhosis, and cirrhosis serving as a nidus for development of hepatocellular carcinoma. That is the most common etiology we see nowadays in our clinical practice, followed by viral hepatitis. Most of these patients have underlying either viral hepatitis B, chronic viral hepatitis B, or chronic viral hepatitis C, again leading to cirrhosis and leading to inflammation within the microenvironment of the tumor, finally leading to development of SCC, and chronic alcoholic abuse leading to alcoholic steatohepatitis, cirrhosis, and development of SCC. So these are the three prime etiological factors: metabolic syndrome, NASH, alcohol, and hepatitis infection. Next slide. So as discussed, viral hepatitis, alcohol intoxication, non-alcoholic fatty liver disease, NASH, obesity. These are the prime factors which lead to development of cirrhosis, leading to chronic inflammation and cirrhosis, and finally leading to the development of SCC. Very important that whenever SCC develops, it has been seen within the tumor microenvironment that there are increased inflammatory cells, T cells. Thereby, there is a rationale for considering immune checkpoint inhibitors, as the tumor is surrounded by these inflammatory B cells as well as T cells, and that is the rationale for considering immune checkpoint inhibitors. Next slide. So coming on to the etiology, as I've previously mentioned, so this was a paper published by Prabhakar et al. This was published in March 2023, and this specifically looked upon the etiology of patients who had HCC in India with and without background of cirrhosis, and it was seen in that study that mostly patient had a metabolic syndrome with the non-alcoholic fatty liver disease, diabetes. So that is the most common cause of patient having HCC nowadays. Previously, it used to be hepatitis B and hepatitis C. Next slide. So coming on to the management of advanced unresectable HCC. So this is the BCLC staging system, the Barcelona Clinic Liver Cancer Staging System, which we commonly use in our practice. So as per the classification, it is categorized into very early stage 0, early stage A, intermediate stage B. So mostly in these subgroup of patients, multidisciplinary care is a standard of multidisciplinary. It is multidisciplinary care where multiple doctors are involved: interventional radiologist, radiation oncologist, hepatobiliary surgeon, and liver transplant surgeon. So mostly local treatment is the standard of care in all these patients. And the role of medical oncologist is not much in these subgroup of patients. The role of medical oncologist comes in patients who have advanced stage, that is BCLC-C. Once there is portal vein invasion or extrahepatic spread, the systemic therapy is the standard of care. And in the first line setting, as mentioned in the BCLC guidelines, we have two options: either to consider for immuno with anti-VEGF, that is atezo-bev, or a dual IO combination, durvalumab and tremelimumab. We will be discussing these trials in subsequent slides. Next slide. So there is this is the time frame of how the treatment has evolved for advanced unresectable SCC in 2007. Prior to 2007, there were no options for treating SCC, but in 2007 came the first anti-VEGF inhibitor, which had shown improvement in progression-free survival as well as overall survival, sorafenib. And nearly a decade later, in 2018, came the option of lenvatinib, which was shown non-inferior to sorafenib. In 2020 was the first, I would say, a landmark study where the combination of atezo-bev became the first line standard of care for unresectable advanced SCC. And recently, we have the Himalaya trial, which was published in 2022, where dual IO combination of tremelimumab and durvalumab was shown superior to sorafenib in terms of improving both progression-free survival as well as overall survival. Next slide. So briefly discussing these trials, the SHARP trial, which was published in 2007, which compared sorafenib versus placebo, and we can see that giving sorafenib improved the median overall survival from 7.9 months to 10.7 months. So again, we can see that the median OS was less than 1 year with sorafenib also. And Reflect trial came in 2018, where lenvatinib was compared with sorafenib, and it was a non-inferiority trial where median overall survival was similar, although numerically higher in lenvatinib, 13.6 months versus 12.3 months. Also, the PFS was also longer, better in lenvatinib, 7.4 months versus 3.7 months. So based upon that, lenvatinib became the standard of care in 2018. Next slide. Now, the rationale for adding IO to anti-VEGF. Next slide. So this was the I Am Brave trial. It was a phase 3 randomized controlled trial where patients who had locally advanced unresectable SCC with Child-Pugh A disease were randomized to receive sorafenib 400 mg BD in the control arm versus atezo-bev in the study arm at a dose of 1200 mg every 3 weekly, atezo, and bev 15 mg per kg 3 weekly. The primary endpoints for the OS and the IRF versus PFS. Next slide. So we can see that atezo-bev did better as compared to sorafenib. The Kaplan-Meier curve separating early in favor of atezo-bev arm versus sorafenib arm, and at nearly 2 years, 18 months, we can see the overall survival was 52% in atezo-bev arm versus 40% sorafenib arm, with a delta of nearly 12%. Similar results were seen for PFS, with at 18 months the PFS benefit were nearly doubled, 12% versus 24% in the atezo-bev arm. So based upon this trial, atezo-bev became the standard of care. Next slide. So this is a forest plot, and it showed that not all subset of patients do derive benefit from the A plus B regimen. Specifically, patients who had viral etiology, hepatitis B and hepatitis C, seem to do better with atezo-bev combination as compared to sorafenib. But patients who had non-viral etiology, that is NASH related CLD and HCC, we can see that the hazard ratio was reaching near unity with hazard ratio of 0.91. So it is important as well to look upon the etiology when we are considering or making your decisions. Next slide. So as we know that bevacizumab being an anti-VEGF has its own side effects, mostly proteinuria, hypertension. So that is the side effects which we have to watch out for. And importantly, as it is an anti-VEGF, the risk of bleed is always there. So it is always important to do a upper GI endoscopy to rule out esophageal varices. If the patient is having large esophageal varices where the risk of bleeding is high, endoscopic varicose ligation has to be done prior starting atizobev. Again, the risk of bleed is always there. So it is safer to consider stride in those subset of patients. Regarding atizo, we have immune-related adverse events, mostly skin rash, pruritus, hypothyroidism. These are side effects which we see commonly with immunotherapy drugs. Next slide. Now coming on to the dual IO checkpoint inhibition. Next slide. So what is the rationale for combining durva and tremi? So as we know that durva is an anti-PD-L1 while tremi is anti-CTLA4. So anti-CTLA4 acts on the lymphoid compartment to increase the number of T reactive cell, while anti-PD-L1 acts in tumor microenvironment to prevent T cell inhibition. That leads to enhanced synergistic anti-tumor activity. Next slide. So Durva and Tremi increase anti-tumor activity by reversing T cell exhaustion and allowing T cell activation respectively. So Tremi blocks CTLA4 allowing for T cell activation, and Durva blocks PTL1 which reverses T cell exhaustion. So when both combine together leads to synergistic action and tumor cell killing. Next slide. So mostly we use a single priming dose of tremelimumab, and it was seen that in solid tumors, ICI regimen incorporating higher doses of anti-CTLA4 combined with anti-PD-L1 are often associated with improved OS compared to those with lower doses of anti-CTLA4 but with increased toxicity. So high dose T combined with D results in initial burst of peripheral T cell in patients with NSCLC. Similarly, in melanoma, the initial dose of IPI plus Nivo caused a proliferative burst of peripheral T cell, which is not repeated subsequent doses. So that was the rationale to give single priming dose of Tremi in the STRIDE regimen. Next slide. So this was a phase 2 dose finding trial, the study 22 trial, where different regimens of Tremi and Durva were used, where Tremi was given at 75 mg, 750 mg alone, and the STRIDE regimen was also tested in this trial. Next slide. So we can see that the stride combination actually had the highest efficacy compared with other Durva and Tremi combination, as well as monotherapies or Tremi 75 plus Durva combination. When the stride regimen was used, the median OS was maximum with OS of nearly 18.7 months. So based upon the study 22 trial, the stride regimen was further tested in the phase 3 setting in the Himalaya trial. Next slide. So this was the landmark trial, Himalaya trial. This was a phase 3 randomized open label multi-center study of Tremi and Durva as first line therapy in patients with unresectable HCC. Next slide. So in this, patients with unresectable HCC with BCLC B or C were enrolled. Patients who had Child-Pugh class A were only enrolled in this trial, and patients were randomized to receive sorafenib 400 mg BD in the control arm versus the stride regimen in the study arm. In the stride regimen, Tremi 300 mg single dose was given, and durvalumab 1500 mg every 4 weekly was administered. The primary endpoint was overall survival, and the secondary endpoint were OS, objective response rate, disease control rate, and the duration of response, as well as the PFS. Next slide. So this was a stride regimen. As we can see, the arm C was the stride regimen where Durva and Tremi was given in combination. Tremi single priming dose of 300 mg was given on day 1, and Durva was given at dose of 1500 mg every 4 weekly. It was repeated at interval of every 4 weeks. Next slide. Coming on to the demographics and baseline characteristics, so all the arms were well balanced with respect to age, sex, and the etiology. Most of the patient in the trial had a non-viral etiology. Around 40% had patient who had non-viral etiology, and nearly 30% of the patient had both hepatitis B and hepatitis C. Mostly patients had BCLC C disease. Nearly 80% of them had BCLC C disease. Child-Pugh classification, nearly all of the patient had Child-Pugh A disease. Next slide. So next slide. So we can see that the stride regimen as compared to sorafenib, The Kaplan-Meier curves are clearly separating early and in favor of the stride regimen as compared to sorafenib, with 3-year overall survival of 30% in the stride regimen versus 20% in sorafenib, with a delta of 10%. Next slide. So overall survival was seen in all subgroup of patients, irrespective of sex, age, region, or the etiology. So specifically for patients who have non-alcoholic fatty liver disease, that is NAFLD, NASH. These subgroup of patients also responded to the stride regimen. So the reason which is given is because patients who have NASH related CLD are immunologically cold tumors, and when we add that single priming dose of tremelimumab, that invokes T cell to kill those cancer cells. So the non-viral etiology also benefited from stride regimen, and in the atizobev we can see that patient who had only viral hepatitis benefited from A plus B regimen, and patient who had non-viral CLD and SCC did not benefited from A plus B. So in such subgroup of patient who have non-viral etiology, it is better to give stride regimen over A plus B regimen. And we can see for all other subgroup, the stride did better as compared to sorafenib. Coming on to the tumor response rate, they were better, 20% versus 5% in the stride regimen. Nearly 3% of the patient achieved a CR. What was impressive of the median duration of response, 22 months versus 18 months. Next slide. So coming on to the side effect profile, we can see that the grade 3, grade 4 treatment related adverse events were lesser in the stride regimen as compared to sorafenib, 25% versus 36%. So overall, it is a well tolerable regimen. Coming on to the immune related treatment related adverse events, so grade 3, grade 4 immune related adverse events were around 12.6% in the stride regimen versus 2.4. But importantly, any immune-related adverse event leading to discontinuation of steady treatment was only 5% in the stride regimen as compared to 1.6% in sorafenib. Next slide. So overall, it is well tolerable regimen. We have used it in our clinical practice. Most of the patients have rash, pruritus, and diarrhea. Most of these are grade 1 and grade 2, and rarely patients have grade 3 or grade 4 side effect profile. Next slide. So this we have already discussed. Next slide.
Sir, kindly conclude your talk.
Yeah. So as per the Himalaya trial, we can see that so the NCCN endorses both Atizobev and Durvatremi as category 1 recommendation for advanced unresectable SCC, irrespective of etiology. Although it is preferable to consider the stride regimen in all patients, as we have now 5-year data as well for stride regimen, and for patients who have large esophageal varices where the risk of bleed is high, again stride regimen should be preferred in those subgroup of patients. And for patients who have non-viral related SCC, CLD and SCC, again stride regimen should be considered over atizobev. Next slide. So to conclude my talk, HCC is one of the top most common cancer affecting Indians, and there is a shift from viral to non-viral etiology, non-alcoholic fatty liver disease. And immunotherapy combination has shown better anti-tumor activity than TKI. Atizobev has been the new standard of care in advanced SCC, and STRIDE has improved OS versus sorafenib and demonstrated an unprecedented 3-year overall survival rate. Although now we have 5-year survival data as well, and it seems to benefit across all subgroup of patients, including non-viral etiology patient population. And it was well tolerated with low rates of discontinuation and GI hemorrhage. And this represents the newer treatment option for patients with advanced unresectable HCC. So with that, I conclude, and thank you.
Thank you, Dr. Nikhil, for the presentation. So moving ahead for the next session is the breast cancer. So I would like to invite Dr. Bharat Vaswani, sir. He's a consultant medical oncology and hematology at Yashoda Hospital. It's talk about ESMO 2025 outlook in breast cancer. So over to you, sir.
Good evening. Good evening. Am I audible?
Yes, sir. You are.
And are my slides visible in full screen?
Yes, sir. Move ahead.
Thank you. Thank you, Abhishek, for the kind invitation. Thank you, Tarun, for the kind invitation. In the next 20 minutes, I'll be summarizing what has gone on in this ESMO 2025. And believe me, probably in a single conference, So much good data, so much practice changing data. I don't remember in the last 5 years I have gone through it. I have tried to summarize presentation. If you can listen to it, I think you can take lot of take home messages. So let me thank you again for the kind invitation. This ESMO was a highlight of 5 things. HER2 neoadjuvant Destiny 5 and 11, triple negative breast cancer advanced Ascent 3 and Tropion breast 2, again practice changing, ER positive post CDK4/6 inhibitor, again two practice changing Evera and Victoria. We had updated analysis of Monarch E. We have a OS advantage and 5-year update of Natal. And last but not the least, the Indian study by AIMS group, where they use neoadjuvant low dose immuno. We have had data from Vijay Patel in head and neck. Now this data came from AIMS neoadjuvant pembrolizumab low dose. So let me start with the first section, trastuzumab deruxtecan in HER2 in pure neoadjuvant and post neoadjuvant as compared to TDM1. So like a Catherine study. So the first study was a neoadjuvant TDXD plus pertuzumab versus Pecli trastuzumab pertuzumab. All of us use either a DOSI or a Pecli. The only thing is versus dose dense AC followed by THP in high risk HER2 early breast cancer. This is again come now in a full text as an NEGM publication in October 29, TDXD per pertuzumab for HER2 positive cancer. So the first phase 3 trial of a new adjuvant TDXD, first time we had it was TDXD plus you give with pertuzumab, and the other comparator arm was dose dense AC followed by THP. So you had added TDXD along with the other 4 cycles of THP. These were high risk patient, majority was node positive, half of them were T3, T4, and the primary endpoint was what you say, the pathological complete response. Remember, this is what we are looking at. Now, when you look into the primary endpoint, the pathological CR was 67.3% with a delta of 11.2. So probably again one of the biggest PET CR or the best PET CR which you can remember in your clinical practice, and it was there irrespective of whether you are hormone positive or not. When you look into the forest plot, this subset benefit was irrespective of the stage or the patient was node positive or node negative. Now my drawback for this study was that the other arm had dose dense Adria with that. There was no arm which had TCHP. Now all of us have mostly changed our practice to carbo, dosi, trastuzumab, pertuzumab. We don't use Adria nowadays in a HER2 neoadjuvant setting. And when you look into the TCHP data, when you look into NAB-PACLI data, Chinese study, or when you look into TRAIN2, this pathological response rate is 66, 67. So is it the other comparative arm weaker? That is why, and we could achieve the same success by giving a TCHP group. This is what I felt is wrong. Now the problem comes is you give trastuzumab deruxtecan, the patient doesn't achieve pathological CR. What do you give next? Do you give TDM1? Because if you see, only half of those who had a residual disease after this TDXD could take TDM1. So what should be the ideal sequence? We don't know. So for me, lot of unanswered question. What is the ideal adjuvant therapy in a patient already taking TDXD without PET-CR? Will TDM work? We don't have a good data to say that TDM1 works well when you have already given a TDXD. And now, as I will be discussing Destiny 05, those data are far more impressive and in a further high risk subset of patients. So should that approach be better than giving a new adjuvant setting? So my thoughts about TDX or Destiny 11 is not practice changing. Now I have not discussed the third arm which had only TDXD 8 doses. This was 4 TDXD followed by 4 THP. That arm had only pathological CR of 43. So that means that only TDXD is an inferior thing. You have to give some form of chemotherapy in a neoadjuvant therapy. No, only single agent trastuzumab deruxtecan is not good. And last but not the least, post neoadjuvant protocol not cure. What to give, they don't achieve a pathological CR. The second study was TDXD versus TDM1 in those who have a residual disease post neoadjuvant. So like a Catherine study. This is again a NEGM publication which has just come 5 December 10. trastuzumab deruxtecan residual HER2 positive early breast cancer. What we know about previously is your data of Catherine, where you have given post neoadjuvant, if they don't achieve a PET CR, you have given 1 year or 11 to 13 doses of TDM1, and there was a 13.7% improvement in IDFS. But the most important thing is there was a OS improvement also. This was a SABS 2023. But the problem in this study was there were two subset of patients which did not do well. After when you give TDM1 was lymph nodes still positive post neoadjuvant. So you had given your TCHP or whatever, there still was possible lymph node. Even if you give TDM1, the 7-year-old DFS was 72. And second was T4 disease or N2 disease as baseline. At the end of neoadjuvant, when you give in the subsequent, their IDF was only 72. So this is what I like about the study was these were the two subset of patients which were taken. So please remember this was not all comers post neoadjuvant. It was only those two subsets, non-operable on day one or operable but not positive post neoadjuvant therapy. Hence, what I feel is there is a place for both TDXD for a very high risk, TDM1 for a slightly low risk, node negative at the end of neoadjuvant, TDXD versus TDM1. And the primary endpoint was IDFS. These are one of the best results, 8.7 delta. So from 83.7, this IDFS was 92.4. Please remember, these are probably the most impressive data with 53% reduction in the risk of invasion. So very, very, very significant. One of the best, I can say the best study in this year in terms of breast. And this reduction was mostly due to reduction in the risk of distant recurrence, where there was a 51% reduction. Now there were less CNS effects. So we always talk about toxicity, that is ILD. But please remember, TDXD versus TDM1, both of them 72% was patient were able to complete. So although there were more side effects, but it did not lead to treatment discontinuation. So what is the pros of this study? Reduces recurrence by half, benefit all across, reduces CNS recurrence. There is no increased risk of discontinuation. But the only thing is the OS data has still not matured, so we have to wait. So what you have to remember is probably TDXD should be considered as a standard option for patients with residual disease. For those patients with inoperable disease on day one, that is T4, N2, and 3, or node positive post neoadjuvant. And if TDM1 should still be continued in those patients who have a operable disease on baseline or who are node negative at the time of surgery. So a bit lesser risk of patient. So is this data practice changing? Yes, a big yes. But we need to select the patient importantly for the two drugs. And there is still a place for in what we say trastuzumab TDM1 intensive post neoadjuvant therapy. The second subgroup of patients that were two trial was in advanced TNBC first line. Please remember, if you have a score of CPS more than 10, you have a data of immunotherapy, you have a data of Keynote 355, and then there was a data with sacituzumab. So these two trials used to look into patients who are immunotherapy ineligible. So a CPS of less than 10 in a first line TNBC, or who are not eligible or you have already taken a immunotherapy in the adjuvant setting. SN3 of Saki and Tropion best 2 of Dotepotamab deruxtecan. Please remember the selection criteria was the same. This will be a game changer once they are available in India. Both had a presentation. NEGM publication of sacituzumab has come, and an ESMO or Annals of Oncology, Dotemotamab. What is the guideline we follow now? If it is PDL1 negative or less than 10, either a chemo or olaparib as well as Olympiad. If you have not given chemo in the first line, you give it in the second line. You have a ASCENT study which says Saki in the later line. And in the third line, based on biomarker, if you have a high TMB, you can give your immunotherapy also. Two drugs which have the same basic principle, they are anti-TROP2. Both. So simultaneously, what is the basic difference? Dotepotamab has a long TF, hence I go back. It should be given once 3 weekly, and sacituzumab doses day 1, day 8, every 3 weekly. So basically both are DNA topoisomerase 1 inhibitor. Now what is the difference between the two? Both have taken those patients who are not eligible for immunotherapy. The only thing is Dotepotamab has taken all patients irrespective once they relapse, irrespective of the interval between curative. Ascent has not taken within first 6 months. Crossover was allowed. in ascent. That is why we could not get a survival advantage. So those patients who could not take Saki in the first line was given the second time. Whereas tropion in dotapotamab, they did not allow cross. This is very important because when you see the difference in the outcome, probably this is the reason why you did not get it. And the other arm, what they used was a double chemotherapy agent. In the chemotherapy arm in Saki, and in a dote, it was a single agent. That explained the low response rate in the control arm. So when you look into the PFS in the two, nearly is equal, 9 to 11 months, with 35 to 40% reduction in the risk of progression. So more or less both drugs goes well. Either of the two waves well. At 12 months, 75% of the patient are surviving. Again, exactly equal, both drugs. Then how to choose which is a better drug? And here come the response rates are better with DOTE, 63 versus 48%. Dotepotamab took patient within the first 6 months also. So these are the two advantages that dotepotamab have. The duration of response equal in both drugs. Now, when you look into OS, dotepotamab has shown OS advantage in the first line, and that is remarkable, with a delta of 5 months, probably because it was a non-crossover. Now, when you look into the toxicity, Saki has more toxicity in terms of hematological and a GI toxicity. And there was more grade C toxicity. When you look into DOTE, the toxicity is lesser. You see the grade 3 between upper and lower, 33, 32, here 87. But these are different. You have oral mucositis, you have ocular toxicity. So regular eye checkup and oral hygiene is very important. The grade 3 toxicity less in DOTE, serious adverse effects are less than DOTE. So DOTE has lot of finer endpoints at the end of the day, which tells us that probably it is better. So a comparison, both PFS advantage, DOTE has OS also. The toxicity profile is less, and the infusion is 1/8 every 21 for Saki and once every 21 for DOTE. So what this test trial said is, yes, it will become first line treatment, replacing chemo in those who are not eligible for immunotherapy. But we need to answer so many questions. What if I am BRCA positive? Should I add PARP inhibitor as a first or as a second line? How do you modify the dose? There is no guideline to say that. What happens when you have a recurrent TNBC after PD-1 in the curative setting? So you have followed your keynote 522 and it has relapsed. Is there a role of rechange of immunotherapy in this? And we need more markers for toxicity. So lot of things, but yes, a very impressive data. The third data, again, this is such a debatable thing. Yes, first line is CDK4/6 inhibitor with AI. The second line was fulvestrant and then came LS second. But please remember that is also gone. Now what you see now is second line will be post CDK will be a SERD with a targeted therapy. And I'll prove this and I'll tell you what is the data. So two studies looked into it. Giredestrant, there are 5 SERDs available now in those with a ESR mutation post CDK4/6 progression. And the second data was PIK3 wild advanced breast cancer, where you combine in a second line post CDK gedatolisib. It is a PAM inhibitor, so PIK3 AKT mTOR inhibitor with fulvestrant and palbo. They may have taken palbo in the first line, but when you combine with these two, you see a response. This was a landscape before ESMO 2025. 6 trials, but you remember only one the trial which shown that the PFS is more than 6 months, and that was also a combination of imlunestrant with the abemaciclib. So that was it. This is a trial. Other trial, no trial has shown improvement of more than 6-month PFS post CDK4, and that is going to train after this study. So Evera looked into those patients who have progressed on CDK4/6 inhibitor, not taken any chemo, and they combined with giredestrant with everolimus. Look at the PFS, 9.9. So 5-6 months with a single. When you combine with a targeted agent, it reaches 10 months in both ESR as well as intent to treat, which were non-ESR also. And when you look into overall survival, there was a trend towards improvement, although there was not because of crossover. The toxicity profile is safe, probably one of the safer drugs that you have as compared to the majority of toxicity was due to everolimus. Now look into it. So suppose if I use single agent SERT post CDK, my PFS is 3.8 and 5.1. What if combined with targeted therapy? My PFS goes to 11.1 months and 9.1 months. So the take home message is that in the second line also, single agent SERT should not be used. You should have to combine with either a CDK4/6 or a everolimus. So combining SERT with targeted is a way to go in future for those who have progressed on first line CDK4/6. The same thing came in Victoria study, but it was PIK3 wild type. They had progressed on 2 or less than 2 lines, and they have already taken a CDK4/6, and they had not taken any mTOR. It is a PAM inhibitor, gidatolisib. Now again look into the PFS, 9 months. So by combining this, you are again achieving that hallmark of 9 to 10, and you are going to the OS of nearly 2 years. So this was the thing that has come now. Before ESMO 2000 now. So what it tells you is, even when you progress on CD4, LST10 as a single agent is gone. I have not put it in this SSBS. There was an Elevate study phase 2 which shows that if you combine with everolimus, this 3 to 5 months PFS goes to 9 months. So this was pre-ESMO. Please remember, I have not given you a slide. This is a new way we will be treating now. Post-ESMO, these are added options that you will now be adding in your guidelines, where you have multiple options and it will be combination, not a single agent. Right? So my thoughts is combination therapy SERDs plus fulvestrant plus a targeted therapy is better than SERD post progression on CDK4/6. But again, we need to know there are 5 SERD. I've written 4, and what will be the ideal post this we don't. My fourth and the last but one is the one slide is updated analysis of monarchy. Very significant. Now we have a OS, and now we have a 5-year data of Natal study. So just concentrate on it. The 5-year continues to have a very good IDFS, slightly low because people have started taking it once they have progressed. So this delta will obviously come down again when you see at 7 years. But the thing is, this quantum of benefit 6 and 4 is very good. So what we saw, this is most important, is in a low risk subset, node negative subset, this was not there. 4-year ESMO data and 5-year ESMO data of Natal shows that even in low risk, node negative, you have a statistical significant improvement in the IDFS. So you can use it in this N0 disease, and there is an improvement. And what you saw in a Monarch study was, although there is a gain of 1.8%, but it is a statistically significant gain in OS. So by giving 2 years of a CDK4/6, you are getting a OS advantage. Looks small, but I think there are a lot of factors which have contributed to it. The only thing to remember is, post this, the biology that we are seeing is a high number of P53 mutant subsets. So when you have given your 2 years or 3 years of CDK and they relapse, then that is a bad biology. Most of them lose their ERPR and they become P53 mutant. So need to understand a lot of new things. So what it update shows is Abima good, it improves your OS. Ribo good, it is also used in better in node negative. Abima has a OS advantage, absolute benefit small, but we need to know post recurrence. And in future, we'll have lots of new question about how to maintain or how to treat post treatment biology and what is the optimal treatment at relapse. The last study, why important? Indian study by Atul Batra, I think proud study, Planet study, by using a low dose Pembro. So only 3 doses of Pembro instead of 8 doses, as in what we say keynote 522, 50 mg only every 6 weekly. So the difference is, see, phase 2 open label, you use dose dense chemo. This is a different. This study has not used carboplatin. If you remember your keynote standard study of 522, they had used carbo with Pacli. There is no adjuvant. So it is a small study. 3 cycles of Pembro every 6 weekly overall, and they try to look into it versus the standard treatment. See the delta of 13.3. Now, when you look into the right side of keynote, the delta remains the same. So what it tried to achieve is, it was a small study, but the quantum of benefit probably remains the same. The difference between other arm remains the same. But the most important for an Indian scenario is less cost and more importantly, less toxicity. So what it summarizes, basically what we need to remember is small size, so it may not be practice changing, and it never compared with the standard dose. So we cannot say that it is better or it is equal. It just wanted to tell you that we can still use a low dose and we can get some degree of benefit. Hypothesis generating, not practice changing. So if I have to summarize my take-home message, 5 take-home message. Destiny, you need to remember, these are the 2 most important studies. Go through your Gradish year-ending review, 20 minutes, go through it. I'll send you the link. These 2 are included. DB5 is post-neoadjuvant residual disease. Very impressive data, 8.3 delta in the very high risk, may become practice changing, 53% reduction. For a section 2, First line treatment in a PD-L1 unfit patient, so CPS of less than 10 or already given, these are better than chemo. You have a 40-50% improvement in the risk of progression, and probably whenever available, they will become a treatment of choice in the metastatic first line setting in TNBC. Section 3, more important, I think. Second line treatment in ER positive advanced breast cancer, previously CD2, CD4. Remember that what you said, Emerald study or the earlier study that are gone now. You have to combine any of your certs with a targeted therapy. Either a CDK4/6 like a Abima as in Ember 3 or in Evera, or now there was a Elevate study where you combine with everolimus and you get a better PFS of 9 to 10 months. For an adjuvant CDK4/6 inhibitor, no doubt now, these CDK4/6 with the OS advantage and the continued benefit and the prolonged carryover effect, they are here to stay. And the last study which I did not is a planet study where probably a low approach may be feasible in future, or when we have a more data, I think we can use it. And I end my talk with my favorite or my most common slide that I use from the famous quote of Socrates. The secret of change is to focus all your energy, not on fighting the old, but on building the new. I thank you all again for a patient here. Thank you.
Thank you so much, Dr. Bharat sir. So, is there any question? Please keep on chat box. So, moving ahead for the next session. And next session, I would like to invite Dr. Anban San Shekhar, Assistant Professor at Advanced Center for Treatment Research and Education in Cancer, Mumbai. It's talk about management of TNBC. So it's over to you, sir.
Hello, good evening, everyone. Hope my screen is visible. Shall I go ahead
Uh,
with my presentation?
Sir, yes, it's visible. Make it full screen, please.
Yeah, sure.
Yes.
So, good evening, everyone. I would like to thank Bharat sir for giving this wonderful lecture. It is really encouraging. Matlab, he's fully detailedly summarized what has happened with ESMO 2025. I would also like to congratulate Dr. Abhishek for giving this opportunity. Let's move on to the session. It is actually a pre session for the session which summarized by the Bharat sir. We're looking into what has happened, what is currently in practice with respect to management of triple negative breast cancer. So we all know the triple negative breast cancer setting has diagnosed or the definition started arising in as early as 2020-25. One area still the triple negative breast cancer's little bit of debate ongoing is where to keep the margin of ER/PR positivity. So somewhere the guidelines says ER/PR positivity less than 1% of tumor cell, and HER2 we all know that it is negative when it is HER2 2 plus and FISH non-amplified, and HER2 1 plus and 0. But when it comes to ER and PR positivity, there is a slight debate or ongoing difference is there, because even in Keynote 522, they included triple negative breast cancer with ER positivity of tumor cells 1 to 10%. So there is a slight difference is there, but all the ongoing by with respect to ASCO CAP and ESMO guidelines, ER/PR should be less than 1% for to diagnosis triple negative breast cancer. Coming to what are the unique features for triple negative breast cancer. When it comes to triple negative breast cancer, it is not only the pathology based definition which is making it unique, but also the clinical morphological feature which is making the diagnosis little more unique. What are the clinical morphological features? One thing, it happens to be in younger age of population. Second thing is the morphology by which it presents. It has a tendency to for early recurrence, especially the recurrence is more common in the lung and brain, is which is more common. Whereas hormone positive breast cancer patient tends to have more recurrence in the bone, HER2 positive breast cancer patient tend to have more recurrence in the liver. This is one of the difference. When it comes to triple negative breast cancer, you need to remember two paradoxes which is associated with the triple negative breast cancer. One is the triple negative breast cancer patient always have higher response rate compared to the rest of the two tumors, but when the response rate is higher, it is also having to have tendency to have early recurrence. The response rate is high, but tend to have early recurrence. This is one of the paradox which is associated with triple negative breast cancer. Another one more important and interesting paradox is whenever the patient is having high grade morphology, high grade tumor, very aggressive in tumor, all these tumor will have higher expression of stromal infiltrating lymphocyte. But these are the tumors having very good response rate with immunotherapy. So that is also one more paradox. Even though there is a high aggressive feature which is associated, but they respond very good when it comes to immunotherapy mediated response in triple negative breast cancer. These are the two paradoxes which is associated with triple negative breast cancer. Coming to how we are going to manage triple negative breast cancer in current scenario. So we have both the setting I would like to discuss, one with respect to early triple negative breast cancer setting and another one with respect to metastatic triple negative breast cancer setting. We have wide range of options. Even though triple negative breast cancer is one of the area, still the targetable therapy is not available. But we have different biomarker based available option currently available, and ADC also kicking more into the feature in terms of management of triple negative breast cancer. So currently we have in the space with chemotherapy, immunotherapy, and we have the option of PARP inhibitor. From 2018, we have almost 5 approved drugs which is entered into the management of triple negative breast cancer setting. In advanced breast cancer, again, we have the incorporation of immunotherapy as well as PARP inhibitor, and ADC is also likely in future come into the practice. How the management of triple negative breast cancer setting happens in advanced setting. So this is with respect to the NCCN guidelines. So we have to classify according to the biomarkers which is available in the data. If the patient is having PDL1 positivity, then the option of combination of immunotherapy will be given to the patient whenever they are feasible for affording immunotherapy in this scenario. And also we need to look for germline BRCA positivity for the patient, as well as we need to look for germline PALB2 mutation. Why germline or somatic BRCA is very important? Because we know that Olympiad study has shown that whenever the patient is expressing BRCA1 or BRCA2, the response rate with platinum olaparib is much good. In fact, the median overall survival with olaparib alone goes up to 23 months. And that is the reason we need to check for BRCA1 and BRCA2. Why for PALB2? PALB2, again, TRPC1 study, they have shown that with PALB2, when we use the response rate as good as 70% in this population. That is the reason we need to check for germline BRCA as well as PALB2 mutation in this patient. Whenever the patient is having PD-L1 negative as well as germline BRCA wild type, these are the patients we are currently going ahead with chemotherapy, but recently with ESMO Asia, as Bharat sir also mentioned, that newer drugs are coming into the picture, especially ADC, sacetamab govitecan, as well as daptopotamab deruxtecan. These two antibody drug conjugates getting into the pipeline in this area as well. Coming to the second line, what is the current second line of option for the patient? Whenever we utilize chemoimmunotherapy as a first line option for the patient, next best available option will be to proceed with antibody drug conjugate based therapy. Based on the level of expression of HER2 receptor, we have the option of TDXD, which stormed into the breast cancer setting, which changed the dynamics of classification of HER2 positive breast cancer, which was a biennial before HER2 positive negative into quaternary system, HER2 low, ultra low, and then HER2 negative, and then HER2 positive setting. So whenever the patient is having HER2 low or ultra low, then TDXD also coming into the picture. Third line, you can go ahead with biomarker based practice. There is the line we are going to do for comprehensive gene profiling. We have other tumor agnostic approval like NTRK mutation, RET mutation. Look for tumor mutation burden more than 10% MSA, even though these percentages much lesser in this scenario. And coming to the chemotherapy option, we do have wide range of option coming from anthracycline, taxane, antimetabolites, microtubule inhibitor, but the response rate with chemotherapy is still in the lower side only. This is with respect to the ESMO guideline, which almost reflects with respect to NCCN guideline. One little change here is they have given option for atezolizumab with combination of nab-paclitaxel also. How this guidelines has been changed with respect to what are the trial setting we change these guidelines. These are all the established as well as emerging marker with respect to triple negative breast cancer setting. We all know that PDL1 is an important biomarker which is expressed in 20 to 30% of triple negative breast cancer, and these are the subset of patients which are going to respond with respect to immunotherapy. For metastatic breast cancer setting, triple negative breast cancer setting, always PDL1 marker testing essential, unlike early breast cancer setting. Here the response rate depends on the PDL1 CPS score, which should be more than 10. Second, with respect to DNA damage pathway, we know there are several subtypes of triple negative breast cancers. Legman has identified and classified into 6 different types. In that, immune rich type is one of the type which is going to have much of DNA damage repair pathway mutation in it. And these are all the patients who are having high expression of BRCA mutation and they respond very well to the PARP inhibitor. Ongoing studies with V inhibitor and check1 inhibitors are there, but still it has to emerge into the practice. Then comes the surface antigen expression. Currently, we have 2 different surface antigen which are targetable with antibody drug conjugate. One is TROP2, which is sacetamab govitecan, and second one is HER2, which is trastuzumab deruxtecan. Next comes the PIK3 and AKT pathway. These are the other subtype of triple negative breast cancer where these pathways are much more common, like mesenchymal pathway. These are one of the resistant pathway which will be respond very poorly to immunotherapy as well as chemotherapy. Possibly we are trying to target the different PIK3 and AKT inhibitors. Still, the success is not reached. Probably in future we may be able to answer for this targetable mutation also. Coming to the whole and soul backbone for management of triple negative breast cancer for most of our Indian patients, that is chemotherapy. What is the data for utilization of chemotherapy in this practice? So most of the time, chemotherapy is a standard of care. The management of chemotherapy differs according to the age and according to the affordable patient general condition also. In general, we prefer single agent chemotherapy because the response rate is almost similar with different lines of chemotherapy, whether it is taxane, anthracycline, platinum, and antimetabolite in advanced or metastatic setting. The response rate varies from 20 to 40%, and the median PFS ranges anywhere from 4.5 to 7 months duration. That is the amount of PFS we achieve with median metastatic triple negative breast cancer setting, and median overall survival with chemotherapy is 13 months. And from chemotherapy, immunotherapy, we are jumping from 13 months to 23 months in this setting. And these are different antimetabolites and microtubule inhibitor. Generally, we use in later lines of treatment when we don't have much good option in this scenario. Why we would prefer single agent compared to double agent, and even in single agent, we prefer 3 weekly regimen over weekly regimen, because the weekly regimen is one of the best regimen for adjuvant setting, but it has not shown similar advantage in advanced metastatic setting. This is one of the trial which is highlighting that when you use 3 weekly regimen, the response rate in first line setting close to 32%, whereas the objective response rate with weekly regimen in first line setting is only 26%. So again, it indicates that 3 weekly regimen is also good for the patient. That is the reason most of our patient we try to continue with 3 weekly regimen, but especially with single agent paclitaxel. Next, moving on to usage of anthracycline. Anthracycline still remains one of the backbone for management of breast cancer, especially in Indian scenario, both in triple negative breast cancer. In fact, in all subtypes of all types of breast cancer, especially in triple negative breast cancer setting. Maybe in the first line, not in the first line, at least in the second line, we try to utilize, especially when they have limited access to newer drugs like immunotherapy or antibody drug conjugate. So we have different options like doxorubicin as well as liposomal doxorubicin. Liposomal doxorubicin still a costlier option for an Indian patient, and doxorubicin still holds the value in our Indian patients also. When we compare liposomal doxorubicin with doxorubicin, the median PFS is almost similar with similar efficacy, but it has better tolerable safety profile. Maybe it could be a better option when the patient general condition is poor in this scenario. Coming to the next and important option, platinum. The platinum is one of the important object in management of triple negative breast cancer patient, which is proven especially in neoadjuvant setting as well as an adjuvant setting. Recent SABC 2025 has also showed importance of addition of platinum to neoadjuvant as well as adjuvant triple negative breast cancer setting. Whereas when it comes to advanced or metastatic triple negative breast cancer, addition of platinum has not shown any great advantage with respect to management of advanced metastatic breast cancer, because there are mixed response with respect to metastatic breast cancer setting. Probably the response for platinum agent driven by the presence of BRCA mutation only. Probably it is not benefiting overall population in this scenario. Next comes the first line treatment option. We all know that PDL1 inhibitor, as I mentioned earlier, germline BRCA is there. Then go with PARP inhibitor or chemotherapy. PDL1 negative, again you go with different types of chemotherapy in this scenario. How immunotherapy comes into picture in this situation? We have IM Passion 130 trial. In this, based on the PDL1 positive subgroup, they received atezolizumab along with nab-paclitaxel. It is an age-old trial which is close to approved in 2019 in this scenario. What is the median PFS which is able to derive? 7 point versus 5 months with an hazard ratio of 0.62. And exploratory OS analysis has shown that median overall survival 25.4 versus 17.9 months. But again, this is a caveat is there. Even though it has got approval in 2019, Roche has voluntarily withdrawn the approval for atezolizumab in 2021 for atezolizumab in this scenario. And this is again showing ESMO guidelines with respect to management for PDL1 positive breast cancer. Again, they are suggesting atezolizumab when the DFA is more than 12 months. DFA more than atezolizumab can be substituted for the patient when the PDL1 score is more than 10%. This is with respect to the different PARP inhibitors used in metastatic breast cancer. When it comes to metastatic breast cancer, we have two PARP inhibitors approved in this scenario. Obviously, olaparib has category 1 recommendation with a little lower recommendation for talazoparib also. Both have shown good response rate, good improvement in median PFS. But when it comes to overall survival, olaparib has shown advantage, whereas talazoparib not shown overall survival advantage. That is why olaparib has better category 1 recommendation. Talazoparib is still not marketed in India by Pfizer, possibly because of the negative result also. And it has shown advantage in this scenario. Coming to the second line option, we have exhausted with chemotherapy, we have exhausted with immunotherapy, we have exhausted with PARP inhibitor in the first line scenario. What we have to offer for the patient in the second line setting? When it comes to second line setting, when the patient is affordable for the newer line of management, we have two antibody drug conjugate in this scenario. Either it could be sacituzumab govitecan or we can consider TDXD if the patient is having HER2 low and germline BRCA negative type. And if the patient we used one line of ADC, we can subsequently use another ADC also, or you can bridge them with eribulin, which require more data to confirm which one we have to use in this scenario. What is sacituzumab govitecan? Sacituzumab govitecan is an antibody drug conjugate which target the antigen which is present in the cell surface, that is proptos the antigen. What is unique about sacituzumab govitecan? It is contains antibody which is mainly aimed at topoisomerase 1 inhibitor. It is the first in class antibody which targets topoisomerase 1 inhibitor. It has a flexible cleavable linker which is hydrolyzable linker which enhances its faster release at the tumor site, as well as the very potent SN38, which is much more potent compared to the parent irinotecan, able to deliver toxic antibody into the tumor cell, which helps in faster tumor lysis in this scenario. When we use sacituzumab govitecan is utilized, the median PFS improved from 1.7 to 4.8 months with an hazard ratio of 0.43, which is really good in this scenario. And it has shown advantage in terms of improvement in overall survival also with a delta value close to 3 months in this scenario. As Bharat sir also highlighted with respect to usage of sacituzumab govitecan, it has comes with fair share of toxicity, especially grade 3 side effects are much more higher. When it comes to neutropenia, it is 46%, febrile neutropenia rate is 5%, which is done in Western population. When it comes to Indian scenario, we obviously expect more amount of toxicity in this scenario. And it also have side effects like anemia, close to 10% in this scenario. These are all the troublesome toxicity for the patient with sacituzumab govitecan. Coming to the next important ADC, that is TDXD in this scenario. Again, it has shown advantage for this is based on the Destiny 04 study, where 80% of population which contains hormone negative patient, 20% were hormone positive patient. Here again, the median PFS is improved from 2.9 to 8.5 months with an hazard ratio of 0.46, and it has shown overall survival advantage also with median OS improving from 8.3 to 18.2 months. Again, it is showing advantage in terms of both PFS as well as OS. When the patient is feasible, we can consider for the option. This drug also has its fast really most important one to address is pneumonitis, which occurs in smaller percentage of population. By now, I think most of the doctors able to identify the toxicity early. The key part in management of this toxicity is to identify the toxicity early and then treat them with drug-free interval or starting on early steroid, which will prevent dreaded toxicity in this scenario. Other side effects like nausea, vomiting, which will be better managed with newer antiemetics, and transaminitis with alopecia, which are the most concerning side effect for our patient in this scenario. What are the ongoing trials and future studies which we have? I think this is again highlighted. We have fair share of patient with metastatic TNBC. The survival actually improved in this scenario compared to the earlier because of the newer drugs which is ongoing into the practice. Probably with even the future trials which is suggesting newer ADCs coming into the front line also, we able to improve the survival margin much higher. What are the key drugs which is coming into the practice? As I mentioned earlier, Dato-DXd, which is showing the highest response rate close to 63% with respect to antibody drug conjugate, which is not seen with either sacituzumab govitecan or trastuzumab deruxtecan. And other AKT inhibitor like capivasertib, but the phase 2 trial is not positive. Probably when we introduce much earlier, it may show the response. We have to wait for the result to see in this scenario.
So
Other drug
sorry
like
for interrupt
toripalimab,
you. Kindly conclude your session.
yeah, two more slides. I'm going to finish. And then VEGF inhibitors also coming into the picture. And this is my last and final slide. This is the key drugs because we have heavy competition in terms of management of triple negative breast cancer in first line setting, apart from chemotherapy with respect to sacituzumab govitecan as well as dato-deruxtecan. As I mentioned earlier, this is good for the patients having better safety profile, and we can use when the patient DFI is less than 6 months. Whereas with sacituzumab govitecan, the DFI should be more than 12 months. And the drug also we can administration wise also feasible because it is once in 3 weekly, whereas sacituzumab deruxtecan should be administered day 1, day 8 every 28 days cycle. So it is a very interesting data. Probably with OS data, we mature OS data, we able to identify more better drug in this scenario as well. With this, I would like to conclude my session. Thank you for giving me this opportunity. Thank you, everyone.
Thank you, Shekhar sir. So moving at for the next session, and this session is sponsored by GSK, and I would like to invite Dr. Satish Sharma sir. He's a consultant medical oncology, Bhagwan Mahavir, Manipal Hospital, Ranchi. So it's over to you, sir. Jhalag is also sharing the screen.
Thank you.
Uh,
Uh, am I audible?
yes, sir.
Hello?
Yes, sir. Yes,
Am I
sir.
audible? Yeah. So I'll thank organizers for giving me opportunity. We are going to speak about the recent advances in systemic management of advanced stage endometrial cancer. Next slide. So these are my disclaimer. Next slide. So the agenda will be to discuss about the rational strategy, landscape, uh, landscape for immune checkpoint inhibitor in endometrial cancer, immune checkpoint inhibitor in second line endometrial cancer, Garnet and KN158 study. Then immune checkpoint inhibitor plus chemotherapy. Next slide. So endometrial cancer is the third most common gynecological cancer in India. The projected endometrial cancer incidence has increased over a period of time. By 2014, it is estimated that we will have 27,000 new cases. Currently, we have around 17,000 new cases with a 5-year prevalence rate of 53,000. Next slide. So the primary therapy for the advanced stage endometrial cancer is chemoradiation or platinum-based regimen like paclitaxel. Or if there is a MSI high, then you can go for chemoimmunotherapy. Or if there is a drive-in HER2 positive or TMB high, then we go for targeted therapy. Next slide. So definitely the paclitaxel has been the gold standard for quite a long time, but the after initial but the long-term outcomes are poor with carboplatin alone, given that the rate that the toxicities along with carboplatin cannot continue in stage 4 endometrial cancer. So next slide. So it was started the endometrial cancer. The initial treatment was started with a hormone therapy followed by the chemotherapy, and then we saw the pembrolizumab coming in with lenvatinib, and finally we have a dostarlimab, which can be given both in MSI high and MSI proficient tumor, and we have a study from durvalumab plus olaparib study. Next slide. So what could be the rationale of immunotherapy in endometrial cancer? Next slide. So MSI high tumors are associated with high neoantigen loads, and MSI high tumors have 10 to 100 times as many as somatic mutation compared to MMR proficient tumors, leading to increase in TILs, tumor infiltrating lymphocytes, and PD1 and PD-L1 expression levels ranges from 40 to 80% in endometrioid and 23 to 69 in clear cell. Next slide. So endometrial cancer is one of the highest occurrence of MSI high among the solid tumors, suggesting the possible potential benefit of immunotherapies. Next slide. So in endometrial cancer, there is a large overlap is seen between MSI high and TMB, suggesting most will benefit from anti-PD-1 and PD-L1 study. So if we see PD-L1 expression only, it is almost in 40% of the patients. When we combine both MSI and TMB, it is in 25% of the patients. And and MSI plus PD-L1 expression plus TMB, it's high in almost 13% of the patients. Next slide. The strategies for immunotherapy in endometrial cancer is either we can go for monotherapy or we can go for chemo plus checkpoint inhibitors or chemo plus TKI or chemo plus PAR combination. Next slide. So
NCCN guidelines, as we have seen that primary platinum-based therapy will be paclitaxel plus dostarlimab, then or it will be with pembrolizumab or with durvalumab. In stage 3 and stage 4, the most of the tumors they have not included carcinosarcoma, and only durvalumab they used only MR proficient tumors. So therapy for recurrent disease, again it is combined with platinum based therapy. And in second line, mostly we have single agent immunotherapies. Next slide. So as we have already discussed this slide, we'll go to another slide. We have another in second line also. When we have HER2 positive, we have trastuzumab, bevacizumab. In recurrent disease, if we have HER2 positive, or if it is a uterine serous carcinoma, then it is trastuzumab can be added. Next slide. So immune checkpoint inhibitor monotherapy. So we have two study, Garnet and KN158. So both were basket trials with endometrial cancer as one of the cohorts, and around 143 cases were in Garnet and 190 patients were in KN158. The endpoints being the objective response rate and duration of response. Next slide. And secondary endpoint of PFS and OS. Next slide. So Garnet, the median, they had a similar median age group, and almost when we see in Garnet, there were almost the patients, more of the patients have the most patient immunotherapy was used in after first line of the treatment. Next slide. So if we see in both in Garnet and Kano, there was a significant number of population which benefited from the single agent immunotherapy, although the figure was slightly high in Garnet group. Next slide. So immunotherapy in second line endometrial cancer, the secondary endpoint being PFS. So we saw at the end of 36 months, almost 40% of the patient had a PFS benefit. Next slide. So again, if the percentage almost 58% would benefit at the end of 36 months had a OS benefit. Next slide. So now the rationale of combining chemo plus immuno plus chemo Ruby trial. So we had the durvalumab, dostarlimab plus paclitaxel, and followed by dostarlimab maintenance for every 6 weekly up to 3 years. So who are eligible? The patient who are stage 3, stage 4 were highly or who had a recurrent endometrial cancer. Stage 3 is so for stage 3 patient who had a low potential for cure either by radiation or surgery alone. Okay. And there was a they were naive to anti-systemic therapy or had a progressive disease after 6 months of completing the systemic anti-cancer therapy, and they had adequate organ function. So it was dostarlimab with paclitaxel was compared with placebo plus paclitaxel. The primary endpoints being PFS and OS, and secondary endpoints with PFS, objective response rate, DSR, and DOR. Next slide. So this we have already discussed this here in Ruby trial. The subject in 3C in patients of carcinosarcoma clear cell were included, and mixed histology with 10% more of carcinosarcoma were included, and the subject were received neoadjuvant or adjuvant system therapy and had a recurrence or progressive disease after 6 months of completing the treatment, where the first recurrent patients were included. Next slide. So when we compare dostarlimab plus in placebo group, they all had a similar age group, and most of the patients all either had a fever stage of 3 or 4, and most of the patients were either ECOG 0 and 1. Next slide. So in a higher risk group, out of all the patients, only 53 people had a high risk histology, which was carcinosarcoma endometrioid. or adenocarcinoma or clear cell. And they had received platinum-based therapy previously. Next slide. So if we go by PFS, almost 72%, the risk of progression or a death was reduced by 72% in patient who received dostarlimab versus patient who were in placebo group. Next slide. Next slide. So the risk of progression was also it was reduced in MMR proficient group. Next slide. So so risk of death was reduced to 31 despite a high proportion of patient in receiving subsequent IO. So even we don't start with initial immunotherapy, if we add subsequently also, those patients will be benefited. Next slide. So if we see the updated OS, we had a significant number of patients when we compare the Stalim group, where we can see with the blue line, it is the voids have been the curves have been widened out, and in that group the median OS has not been achieved versus in 31 months in placebo versus chemotherapy arm. Next slide. Even in the patient who has MMR proficient group, there also the benefit was there, that was 27 versus 34 months. Next slide. Now this is a forest plot. It will see that even in the histology wise, irrespective of the age group, there was a benefit even in the patient who are more than 65 years of age. In the all histology category, endometrioid carcinoma and other high risk status, which we discussed, almost 53% of the patient, they had a benefit. Irrespective of MSI high, there was a benefit, although the benefit was much higher in patients who are MSI high. And in MMR proficient group, the benefit, quantum benefit was less. Patient who was in stage 4 and recurrent disease, they had a benefit. And next slide. So this is the objective response rate of when we compare in MMR group versus proficient group. Of course, the response was higher in patients who are MSI high. Next slide. So dostarlimab versus placebo, what we have seen that there were hardly any serious side effects. The regular side effects of immunotherapy was with dostarlimab group. Next slide. Next slide. So comparing the Ruby, Kane 868 and DUO, durvalumab plus olaparib or durvalumab with carboplatin plus paclitaxel. Next slide. The primary endpoint being OS in one of the study and PFS in both Kane 868 and DUO study. Next slide. Next slide. So the PFS in first line therapy in proficient MMR population, it can be seen that it is highest with dostarlimab. And next slide. So OS data for dostarlimab is yet to mature, but we have seen that it has been benefiting in a patient in both with MMR proficient and deficient, even with us in first line in MMR population. Next slide. Next slide. So can we go to the summary slide? So the key takeaway is the benefit of adding immune checkpoint inhibitors plus chemotherapy in first line, and it is more pronounced in proficient in deficient MMR group or MSI high population. In MMR proficient group, there is a benefit, but the quantum benefit is very less, and there is no DGCI approval for using dostarlimab in MMR proficient group. There is a slight increase in opinion PFS, and the OS benefit is there with the MMR group, although there is a slightly benefit of OS in patient with MMR proficient group. And in second line also, patient get maximum benefit of IO in both in terms of overall response rate, PFS and OS. Thank you. Next line. So over to the organizers.
So thank you so much, Dr. Satish sir. So moving ahead for the next session, and this session sponsored by Merck. And I would like to invite Dr. Abhishek Anand sir. He's a consultant medical oncology, Paris Hospital. So it's over to you, sir.
Thank you, Gitika. So this will be the last presentation of the 2-day virtual conference. So this is about the maintenance evolumab in metastatic urothelial carcinoma, and what is the right way of sequencing the chemotherapy and immune checkpoint inhibitors in the metastatic urothelial carcinoma patients. So bladder cancer in India is the 7th most common cancer in the world, and India it is the 11th most common. And the mortality wise, it has got the highest mortality from bladder cancer in the world in India, and it is somewhere around 12,353. If we talk about the first line treatment with platinum based chemotherapy in patients with locally advanced and metastatic urothelial carcinoma continues to be guided by the platinum eligibility criteria. And we have got different criteria that includes ECOG performance status of 2 or more, heart failure status, whether it is class 3 or more, creatinine clearance, grade of hearing loss, and grade of neuropathy. So, what is the rationale for evolumab maintenance in metastatic urothelial carcinoma? So, chemotherapy, when we give, decreases the tumor burden to achieve disease control and increase the immunogenicity of the tumor microenvironment. And when we plan for immune checkpoint inhibitor, evolumab, it is more effective in patients with reduced tumor burden and a high mutational burden like urothelial carcinoma patients. The cytotoxic and immunogenic effects of platinum-based chemotherapy provide the opportunity to enhance clinical efficacy with immune checkpoint inhibitor maintenance therapy. In a randomized trials, up to 80 to 90% of the disease control with first-line platinum-containing chemotherapy in patients with locally advanced or metastatic urothelial carcinoma has been seen. Coming to the Javelin Bladder 100, so it is a phase 3 randomized open label study where patients who were unresectable, locally advanced or metastatic urothelial carcinoma with measurable disease, stage 4 disease, received standard first line chemotherapy, that is 4 to 6 cycles of cisplatin or carboplatin along with gemcitabine. And after a treatment free interval of 4 to 10 weeks, those patients with complete response, partial response, or stable disease were enrolled and randomized 1:1 to receive either evolumab maintenance or best supportive care alone, with the primary endpoint being the overall survival. These are the baseline characteristics. Median age was 68 years. 76% of the patients were male, and 61% of the patients were having ECOG performance status of 0. Location of metastasis, visceral metastatic disease was present in 55% of the patient and non-visceral in 45% of the patients. First line chemotherapy as gemcitabine and cisplatin were received by 52% of the patient, and 42% of the patient received gemcitabine along with carboplatin. If you see the median OS measured from the start of chemotherapy, for evolumab plus best supportive care, it was 29.7 months, and for the best supportive care alone, it was 20.5 months. So it was significantly better for patients who received evolumab maintenance as compared to the placebo. If you see the median PFS, it was also better for the evolumab maintenance arm, 5.5 month the median PFS, and in the best supportive care alone it was 2.1 months. In the overall population, the risk of disease progression or death was reduced by 46% in the evolumab arm. So does the first line CT regimen affect the outcome of avelumab maintenance? So whether we give a cisplatin or carboplatin along with gemcitabine combination, it does not differ. So it is the benefit of avelumab maintenance is there irrespective of the first line chemotherapy regimen which we have given or which the patient has received, and does the response to the chemotherapy matters before starting the avelumab maintenance. So irrespective of complete response, partial response, or stable disease after the first line chemotherapy, the avelumab maintenance do show benefit as compared to the best supportive care alone, and this has been shown in this Javelin 100 trial. So the Asian subgroup represents 21% of the overall population of Javelin Bladder 100 trial, and the Asian population that also included Indian patients. The benefit of avelumab was maintained as it was seen in the original trial result as well. Asian patients showed similar OS benefit as that of overall patient population. So the question arises, how long would you like to continue avelumab maintenance? The median PFS of 26.7 months in patients who were exposed to Bavencio, that is avelumab maintenance, for more than 12 months, and OS was not reached. So we have to continue avelumab till the patient is in good health and not having any progression of the disease. Avelumab first line maintenance in patients with advanced urothelial carcinoma with or without diabetes mellitus. So patients who are having metastatic advanced urothelial carcinoma do have some kind of comorbidities, and the OS was present. OS benefit of avelumab maintenance was seen irrespective of the whether the patient is having any comorbidities or not. Indian real world evidence also suggested almost similar kind of benefit with avelumab maintenance, and the OS outcome for avelumab first line maintenance are reflected in most of the real world studies as well. Safety wise, the long term safety profile of avelumab maintenance supports continued treatment until disease progression, and it also demonstrates a consistent safety profile across clinical and the real world studies. So, how to sequence the therapy or the regimen in the advanced urothelial carcinoma? First line chemotherapy should be gemcitabine along with platinum agents, which can be either cisplatin or carboplatin, and patients who do not progress on this first line regimen should be given the option of avelumab maintenance, and it should be given until disease progression or unacceptable toxicity. And at the time of disease progression on avelumab maintenance, patients should be initiated on the second line therapy. That could be any second line chemotherapy options or maybe some target or immune checkpoint inhibitors. So this is the first line therapy maintenance and as well as the subsequent therapy flow chart, which suggests the same sequencing which we have discussed in the previous slides. With the multiple agents available in the treatment for metastatic urothelial carcinoma, sequencing them becomes extremely important to increase the survival. And here is how most of the trials have also suggested that to start with, we should be giving the option of a first line platinum based chemotherapy, and if the patient is having complete response, partial response, or stable disease, avelumab maintenance should be given till disease progression. At the time of disease progression, we can give second line enfortumab vedotin or any other option depending on the molecular profiling or immune checkpoint inhibitors, and this sequencing gives a median OS of 40 months in metastatic urothelial carcinoma, and this has been shown in Evidence study and EuroQ study. Both in both of the trials, the OS median OS was more than 40 months. This is the same thing. To summarize, up to 90% of the patients are eligible for maintenance treatment, and first line avelumab maintenance leads to median OS of approximately 30 months, superior OS regardless of prior platinum based chemotherapy regimen, duration of PBC, and response to platinum based chemotherapy or treatment free interval. Robust real world evidence data with consistent efficacy and safety are present, and 80% of patients are eligible for second line therapy post avelumab. Unprecedented median OS of 40 months and more with sequencing of first line avelumab maintenance followed by second line enfortumab vedotin or any other therapy. So with this, I would like to conclude. Thank you.
So thank you, Abhishek Anand sir. And thank you to all esteemed faculty, delegates, and pharma colleagues to join day one and day two session. Thank you for BMS, AstraZeneca, GSK, J&J, Merck for your valuable participation and support. So thank you so much, Abhishek Anand sir, to organize
Thank
this
you.
event.
Thank you, everybody. Thanks to all the faculty for having excellent session on both day one as well as day two, and having important updates of cancer in the previous 2 or 3 years. And we would like to thank our academic partners as well, including the AstraZeneca, BMS, GSK, as well as Merck team. And most importantly, we would like to thank our event management team, Horizon, and the CRSF for organizing this virtual conference. Thank you so much.
Thank you, sir. Thank you, Tech Support and Jhalak, for